people join as they come in, but just a very quick introduction. So I'm the development coordinator at Arts, Culture, Health and Wellbeing Scotland. We're a national network that linking together and advocating for and supporting those working at the interface of arts, culture, health and wellbeing in Scotland. Throughout this week, we've curated an online programme of conversations so that obviously it's Healing Arts Scotland. There's activities happening all over the country. There's been a series of conference programmes in Edinburgh, Glasgow, Aberdeen, and today up in Orkney. And the online programme was really to broaden that out and bring some of the discussions that have been happening in person in rooms out to anyone that would like to. And from arts, culture, health and wellbeing's point of view, these are the kinds of conversations we do across the year. So that's the bit that we have been doing as part of the Healing Arts Scotland Week. So I'm going to hand over to the panel for today, and we'll just touch base at the very end again. But in the meantime, I'm just going to flag up that I'm recording this call. Everybody who signed up for it, you'll be sent a link. So if you want to watch it back later or share it with colleagues, you will get a link sent through to you, and it also means we can share it more broadly afterwards. But it was just to let you know that the call is being recorded. All right, thank you very much, and over to you.
Hi, I'm Chris Fremantle. I am a researcher and lecturer at Grey School of Art in Aberdeen. I'm a board member of ACHUS of Arts, Culture, Health and Wellbeing Scotland, and my work in the arts and health domain is mostly focused on managing public art projects in capital programs, but also doing evaluation and documentation work, which I do with it's a great privilege to be here, and this follows on from a really fabulous session yesterday in Aberdeen. So the panel today, we have Liv Coburn, who is a senior primary care link practitioner in Aberdeen. We have Alison Leach, who's the joint community link worker, assistant service manager, and leads the social prescribing network. And then we have Bogdan Shiva Gurika. I'm sorry if I've pronounced that wrong, Bogdan, who's Global Clinical and National Academy of Social Prescribing. So we have local, national and international speakers. And then we have Sally Thompson, who's the director of Grampian Hospital Art Trust. And because we had a social prescribing discussion in person yesterday in Aberdeen, Sally's going to just give us a few key points that came out of that as a sort of scene setting exercise now. And then I will go to Liv and to Alison and to Bogdan. They will each give us 10-minute presentations. I'll come back to Sally, and then I will open the floor for discussion. And at the end, I will ask each of our panelists to give us one headline takeaway. So that's the plan for this session. And I'm on timekeeping, so I will make sure that we get to a good amount of time for questions and answers from the people in the room. So can I hand over to you, Sally, and give you 5 minutes or 4 minutes to just summarize a few key points from yesterday's discussion?
Yeah, so the panel yesterday existed. Liv, who's here, is in the room. Chris was in the audience. It was myself. It was and 2 members of Public Health Grampian. One is a public health practitioner in Grampian, and the other was somebody who is, and I have to get them. It's the place and networking place and partnership networking that we've set up, that's been set up in Grampian, which is looking at social prescribing across the northeast. And Liv, you'll give me the right I sometimes get the name for that wrong, but it's a place and networking partnership, and that's got many members in the northeast looking at how social prescribing. So Alison gave us a definition of social prescribing, which I'm not going to try and remember and put forward to you, but I'll leave that to Alison to give us a definition of what social prescribing is. What it came to me was social prescribing is not just one thing, and it showed you the various ways that, and the panel described various ways that social prescribing is in action in Scotland, both informal ways and formal ways. Alison also described the potential development of a social prescribing framework, which again I'll leave that with Alison Leach to give you more information about that, where we have and haven't got. One of the other areas we looked at is how social prescribing is a person-centered approach. It's about the link coordinators working with the individual person, and that the arts is part of a rich set of assets that link workers in social prescribing are looking to engage with. We're just one of many. There's many reasons why an individual could be referred to a link worker, and the arts is a very powerful. We've heard all week how powerful the arts is to well-being and how powerful it can be to be involved in the arts. Within social prescribing, we are one of many areas of it. So that we looked at the challenges of social prescribing, we looked at the beauties of social prescribing, and we did touch on funding, but we all know that's an issue, but we didn't go too much into funding. But we looked at person-centered, being about people, and where the arts fit into that, and how we as arts organisations could potentially be community assets, I think was the description of where we fit into this matrix. So I am going to hand back to Chris and suggest, have I mentioned everything we talked about yesterday?
I think that's great. And then I think Alison is going to give us a very brief input on, because there was a roundtable discussion in Glasgow around social prescribing as well. So Alison, do you want to pick that up?
Yes, thank you. On Wednesday, as Chris said, there was a closed door roundtable discussion on perspectives of social prescribing. There were representatives from Healthcare Improvement Scotland, Jamil Arts and Health. We had Ogden's colleague Monica from the National Academy of Social Prescribing in London, and we had representatives from the Welsh Government who did a public consultation on social prescribing in 2022 and are working through the results of that. And we had representatives from the Irish Social Prescribing Network and the Irish Government, because they have a social prescribing framework in place. One of the main aims of the Scottish Social Prescribing Network is asking the Scottish Government to bring in a framework, because there's amazing work happens on the ground in Scotland, but there is no lead, there is no framework, there is no overarching person within Scottish Government or department that leads on this. So that was certainly my aim, was to get those discussions going around the table. We also had Angelina Foster, who's head of Public Health Scotland, and Gregor Smith, the CMO, were in the room. So they've well and truly heard the message, and just again where the arts and culture fit in with that wider social prescribing setting. So it'll be really good to find out what comes out of that session, because I think there's a lot of follow-up with both the CMO and the Minister, Marie Todd, who social prescribing is now a ministerial responsibility, and it sits with her.
Brilliant. Thank you very much. So I think we're going to turn to Liv Coburn, who, as I introduced, is the primary care link practitioner in Aberdeen, and is, in a sense, at the sharp edge of dealing with people being referred for social interventions. And so maybe can I just hand over to you, Liv, to talk a bit about, about this from your perspective on the ground.
Yep, sure. So, as I said, I'm one of the seniors for the Aberdeen Links service, which is based in Aberdeen. We're actually employed by SAMH, but we actually work for the Health and Social Care Partnership in Aberdeen. So we're part of the primary care, and we're all based in GP practices. So at the moment, there are 21 of us sort of working across all the GP practices in Aberdeen. We receive referrals from people connected with the practice, so that can be anybody in the practice. Doesn't have to be a medical. It can be the receptionist even that refers to us. And sort of trying to put it into a bit of a context for the session we had yesterday, I sort of focused on the sort of first quarter of the year. So sort of from April to June, we had 399 referrals. Our 5 top categories, which will change every quarter, but for that quarter, the 5 main ones were mental health, benefits and finance, long-term conditions, activity and isolation. So that was the 5 top reasons for referrals in the last quarter. And of those 399 referrals, we actually made 944 onward referrals. So, you know, that gives you an idea of the complexity of the sort of cases we're getting. You know, people don't just come for one thing. They've got a number of things, you know, benefits, finance up there, housing, you know, Aberdeen doesn't have many houses available. So, you know, the benefits and finance would always be one of our top ones, but I think it's interesting that activity, you know, is up there. It's sort of number 4 for this quarter. So we actually referred 69 people onto arts and cultural sort of services. And that's not like a nice thing for people to do. That was actually part of the reason why they were referred. So, you know, somebody that was referred, you know, wanting an activity because they've got a long-term health condition. And as was mentioned yesterday, we have an organisation, City Dance, that actually specifically does classes for people with Parkinson's. We are also part of the PDS strategy, so we deliver support to people that are diagnosed with PDS, with any sort of dementia. So for us, a lot of the sort of art sort of services that are available in Aberdeen are really helpful. So, you know, we referred on to sort of choirs, we've referred on to art sessions, crafts, we referred on last quarter. So, you know, of the 69, of the 944, 69 doesn't seem a big percentage. Mm-hmm. But however, you know, I think what I was trying to say yesterday was that a lot of the reasons that we get referred, so the referral reason that's on the referral form isn't always the priority for the person. So we were really keen on making sure that the sort of the meaningful conversations that we have with people at the very beginning are identifying their priority and not what the GP or the person that's referred thinks the priority is. And I think that's really important, because I would say 99.9% of the time is that the referrals that we get through originally actually don't identify with the priorities for the person. So it's actually sort of identifying what the priorities are, working through that, and then, you know, we work with people until we have positive outcomes, because it's not one size fits all. I think a lot of the barriers for people getting out there and actually connecting with their communities is getting through the door the first time. So we would be involved in that. We would be involved in helping people get through the door the first time, maybe once or twice. And it may well be that the first sort of service that, you know, we're connecting them with doesn't work. So you're maybe trying that a few times. But, you know, we're very lucky that we're not time limited. So we can work with that person until we have a positive outcome. Average time probably work with people with probably between 3 and 6 months. So we have the opportunity to be able to do that. I mean, we have high caseloads and we do have waiting lists, but, you know, we do the best, because I'm a great believer in, you know, if you don't break the cycle, they'll just continue on the hamster wheel. And I think, you know, we get real feedback from people saying to us that this is the first time that somebody's actually listened to them and actually understood what their issues are. We're all for supporting people to actually live the life they wish to live. So, you know, helping with benefits and housing and everything else is fine. But I think we need to look at further than that, you know, if people want us to do that. I think it's great. I think yesterday that session, you know, as I was saying, you know, somebody was asking, I think I said we've got 523 organisations in our database that we connect people with. And somebody was asking, how do we do that? And I did say, I mean, we literally walk the streets. So we actually, that's how we do the community mapping. We get out there, we get involved, and we see what actual groups are around. And a lot of groups, a lot of groups that are not constituted, that never will be constituted, that have actually got together because there's people, like-minded people within communities want to try and do something. You know, they're the ones that often, you know, are hidden under the radar. So it's really about getting involved with your community.
Liv, actually, somebody's asked a question in the chat, which actually came up yesterday, about informal and formal. So it just for a moment, it'd be really useful if you just talked a little bit about that difference between what goes on as sort of informal social prescribing and then what goes on as formal social prescribing. Because you were really clear about that yesterday.
I'll try and remember what I said yesterday. I think you know, obviously we're you know, it's like we're the professional, we're the statutory. This is how people get through. This is how people access it through their GPs. However, as part of our role as well, it's about linking people within the community. I think I spoke about, you know, a referral I'd had for a gentleman that had suffered a stroke. He was at a class with some other people who had suffered strokes, and they were in a sort of rehabilitation exercise class for 12 weeks and it stopped. You know, he came and he said to me that he really missed it. He had a really supportive family, but he didn't want to burden them. And he was feeling a bit isolated, and his mental health. So I was thinking, well, okay, got in touch with the hospital. They were really helpful in sort of saying, yes, they could sort of publicise the fact that they were going to get a group going up and set up. I actually linked them in with like church drivers, you know, people that take folk to church on a Sunday. And then they actually met in Dobbies on a Wednesday morning, set up there, and they called themselves the Grumpy Old Gits. And, you know, it was just about coming together and, you know, having that opportunity. Now, that actually I know has developed onto other things. So they've set up a sort of exercise class, not, you know, this is them doing it within themselves, this sort of informal sort of social prescribing. They set up a book club. I think they've set up a cinema, going to the cinema once a month. So, and that was only linking people together that, you know, had an interest, that had a stroke. So they were all, that linked them, but it was also about giving them the ability to come together. And from that it developed. And I think that's what's really important, because to me, they're the most successful. It's, you know, when it's from the community up, it's not about, you know, us sort of going out there and, you know, saying, well, go here, there and everywhere. I think it's much, much stronger when it's actually from the community. And, you know, we did see what happened during COVID, where communities were up and running well before statutory services had anything in place. So I think it's about trying to nurture and support and connect people together, which is what we do.
Brilliant. I'm going to suggest we now move on to Alison to get the sort of national perspective, having heard that what's going on a very specific local level, both, you know, in terms of what's people self-organizing as well as what you're coordinating. We move on to Alison and look at the national level. That'd be great. Can I hand over to you?
Thank you. So as it was mentioned, I lead on the Scottish Social Prescribing Network, and I also I'm the Assistant Service Manager of the Edinburgh Community Link Worker Programme, so a lot of what Liv has just explained completely recognise that from the link workers in Edinburgh. The SSPN started in 2020 as a group of volunteers working in social prescribing programmes coming together, and just last year we got some funding which allows me to work on it 2 days a week. I started as a link worker for the Edinburgh Network in 2017, working in 4 practices that were in areas of high deprivation, and I've moved up to the assistant manager role in 2022. So it's a long time since I've sat in front of a patient, and I certainly haven't been a link worker through a pandemic and then a cost of living crisis. So the role has changed considerably. SSPN held a parliamentary reception just over 2 years ago, and 5 months ago we got social prescribing listed as a ministerial responsibility under Mary Todd. So we have come a long way, but we do have a long way still to go. I just want to touch on a little bit of the wider social prescribing, and Bogdan, I don't want to steal anything that you're going to say, but there is an internationally accepted definition of social prescribing, and I know Sally touched on that earlier. That came out of Caitlin from Canada doing a PhD study on social prescribing, and it was agreed on by 48 experts from 26 different countries and has been accepted by the British Medical Journal. This all came from part of the International Social Prescribing Collaborative, which is a group of worldwide partners who recognise that what keeps us well is more than just medicine. I think the collaborative's up to over 32 members, and we meet every 6 weeks. And honestly, it's the best meeting that's in my diary. It's an hour of people coming together from all over the world. We change time so that we can accommodate the different time zones, and people just come together to talk about how social prescribing is expanding in their country. And I can put a link to the latest worldwide report in the chat in a little bit. But one of the things from that definition is there's often a misconception as to what social prescribing is, where community groups and activities often describe themselves as a social prescribing programme, where in fact they actually provide the prescription that we would link somebody into. Groups and services absolutely have a vital role to play, but the important part for me is that for social prescribing, it needs that person to make the link into the different services. So what does social prescribing look like in Scotland currently? Well, in 2016, there was an SNP manifesto pledge to introduce 250 link workers across Scotland, and the latest figures show that there's just over 320. The link workers are supported by the Scottish Community Link Worker Network, which was established in 2020, hosted by Voluntary Health Scotland, and is funded by the Scottish Government. And you may have noticed from the chat that Roisin Hurst, who's the project manager for that, is on this call. The Social Prescribing Network, as I mentioned, was also established in 2020, and just last year received some funding to allow the network to grow, focusing on developing support and coordination of the wider social prescribing strands, including sectors such as sports, culture, academia and research. We've undertaken some basic mapping which shows that most health boards in Scotland have some social prescribing programme. But this could be link workers, social prescribers, local area coordinators or community connectors, although the majority are GP-based link workers. There was 2 larger social prescribing programmes which have ended due to lack of available funding, and these were Spring and Empower. Both of these programmes covered Northern Ireland, and Empower covered the south of Ireland as well. These programmes complemented the link worker programme really well, looking at remote and rural areas, and also looking at a technology-based programme. And there is an evaluation paper on Empower, which is in the public domain, that was carried out by the University of the Highlands and Islands. So the challenges in Scotland that SSPN recognise is that there are no data requirements for the link worker programme. Initially, there was 5 early adopter sites that started out, and there was minimum core data requirements, which were dates of birth, gender, ethnicity, postcode, and the reason for referral, but this was never enforced. And I think this really holds us back, because for the GP link workers, we really strive to be part of the multidisciplinary team, and nobody questions the value of a mental health nurse or a physio or a pharmacist, but link workers are always questioned about their value. And I don't think we're going to stop that until we get some real quality data evaluation and research. And what I see is there is so much pressure on money just now that if we were to get our data in line, then that could be passed on to the third sector and the community groups, so that they can then use that data for their future funding application. There are a number of researchers in Scottish universities that are desperate to do some evaluation on social prescribing. And Ireland and Wales both have research hubs set up. Again, the lack of leadership and the framework that we're really lagging behind in Scotland, that stops us from looking into that any further. There was research from 2019 on the effectiveness of link workers, but it was really inconclusive. However, there's currently the National Institute for Health Research has funded a £5 million research project into GP-based link workers in England and Scotland, and Glasgow and Edinburgh are two of the sites that are taking part. Professor Stuart Mercer at Edinburgh University was involved in the original 2019 research project and is involved in the current research through then at IHR, and that is due to report early next year. So it'll be really interesting to see the results from that. Again, go back and referring to link workers, there's a lot of variation in the link workers. We know that there's equivalent of an NHS band 4 salary being paid right up to a band 6. And link workers can vary. They can be employed directly by the Health and Social Care Partnership, some within the NHS directly, but the majority are in the third sector, which shows that there's a huge variation in terms and conditions, which just causes quite a lot of upset. Last year, there was a funding issue over the Glasgow community link workers, and the Glasgow Health and Social Care Partnership decided not to fund some of the Glasgow link workers going forward. But this was then interpreted across Scotland and further afield, that there was cuts being made to all Scottish link workers and that it was a Scottish Government decision. This wasn't the case. However, the Scottish Government has, as a result of this, set up a national advisory group to look at link working in Scotland, and they will report back to the Cabinet Secretary later on this year. And myself and Roisin are both on that advisory group, as well as a wider stakeholder. As I touched on, I think Scotland really lags behind the rest of the UK and Ireland. England has the National Academy for Social Prescribing, which Bogdan represents, and it did have a head of social prescribing within NHS England. I mentioned that in 2022, Wales carried out a really ambitious national consultation on social prescribing, and they launched the results of this at the end of last year, and work will continue as they work through the results of that. Wales, I've mentioned as well, Wales and Ireland both have, Wales has the Welsh School of Social Prescribing Research, and Ireland has a Social Prescribing Evidence Hub, which brings together all those people that are interested. And everybody talks to each other and is more than willing to share, and the National Academy play a fantastic role in bringing people together and sharing information and helping. But I really do think Scotland needs to, or Scottish Government really needs to step up and formalise this more. One of the conflicting issues is that social prescribing sits under the Minister for Social Care, Mental Wellbeing and Sport, whereas link working sits directly with the Cabinet Secretary for Health. I have never known more about government politics than I have in the last few years. So just a bit of general information about social prescribing and where it fits. We know that 1 in 5 GP appointments relate to social issues. 1 in 5 adults are on antidepressants in Scotland. We really do need to do more.
Yeah.
We all know that there's the pressures in primary care, and there is no let up in sight. So we really do have to look at the alternative. Social prescribing was mentioned in last year's CMO annual report, which was entitled Doing the Right Thing. And I presented as part of that launch, which gave social prescribing a really good platform, which resulted in a lot of inquiries from both within the NHS and Scottish Government. And the first chapter of the CMO's report last year stated that care is human. It's about personal interaction, uncertainty, co-creation, and compassion in managing risk, anxiety, and hope. It's by the power of relationship and being able to jointly identify the issues that affect us, our preferences and our goals. And I think that this embodies social prescribing perfectly. Last year, there was a cross-party inquiry into non-communicable disease prevention, which highlights the projected increase in the burden of disease by 21% by 2043. And non-communicable diseases are the leading cause of death in Scotland, and many of these are preventable. And this is where social prescribing really has a role to play in helping with this. In addition to the health policy, Scottish Government referred to social prescribing throughout sports, arts and culture strategies, and it's widely recognised that engaging in cultural activities can reduce social isolation and improve social connections, whilst engaging in physical activity can lead to improved mental health, help with weight issues and overall health and in general.
That can I sorry, Alison, how are we doing?
Just about to wrap up.
Excellent, thank you. Sorry.
It was just to touch on a little bit, going back to my Edinburgh hat on.
Yes.
We have seen some really fantastic achievements with our link workers employed by 9 different third sector organisations, and they constantly feed back the gaps and pressures out. One of the things I do remember from having a caseload was that patients that had come through the community mental health teams or had been in secondary care, when they were discharged from those services, they were always looking for art groups. And what we've seen is, because of the link workers being employed in third sector organisations, there's funds available that for joint working with primary care and the third sector, and we've been successful in securing funding to run some programmes which have then given the evidence, and the third sector have then been able to take that evidence to apply for future funding so that these support groups are able to continue. So it just showed that collaborative working, and I just think that's what social prescribing really embodies.
That's brilliant, and that's a really, really useful note to move on to hear from Bogdan from an international perspective.
Thank you very much, and it's lovely to see you. And first of all, huge thanks to Alison for all the work that she's been doing in Scotland for the past 4 or 5 years, probably more. Alison, I remember we met in Scotland a while ago, and I think the word that describes your work is tenacity. You just never wanted to let go, and I think you brought things to a much better place. There's much more work to be done, but I think you've got a big army behind you now, and I think collaborating with each other is what will move this forward. I'm Bogdan, and I was described on a previous call as coming from the dark side because I'm an emergency medicine doctor by day, and so I also work for the National Academy for Social Prescribing. I'm the national clinical lead, and I also work as the global director with the international collaborative, which I posted the link that Alison mentioned earlier in there. But I'm just before a 12-hour shift in the emergency department, so I always have to remind myself why is this important? Why is this relevant? And so I know we can talk for hours, but I'll try to make this very, very succinct and very brief. But these are the first few things that I think Alison also pointed out, but I'd like to remind you of, and these are statistics from the UK, actually, not just from England, but from the UK. And so 1 in 5 doctor appointments for pure social reasons. Actually, when you look at the emergency admissions, it's 1 in 4. So 1 in 4 people that come and see me or will end up in my emergency department would come in for pure social reasons. Loneliness, isolation, they might come in with palpitations or a headache. We do all of our tests and we find out that there's a social root cause to their issues, actually. So yes, they might have palpitations, but they may have an anxiety attack because of their debt or lack of finances or what's happening at home. And then when we look at what we do for those individuals, people like me are pretty bad at finding out what truly matters to them. And like Liz was saying is doing, we don't do that because we don't have time, Liz. And so what we do is we put them on a bunch of pills, and then they come back to us with more side effects, and we put them on more pills, and then we complicate the problem even further, and we shoot ourselves in the foot. So 1 in 4 emergency admissions are for pure medication side effects. So 25% of the people that come into hospital are there for side effects from medication that should have never, ever been prescribed. And not to mention what Alison was saying about the rise in chronic conditions. We are having people live longer, which is great, of course, but it's not good for the medical professionals who will get to see people again and again and again in the hospital environment. And so in 2019, England decided to create a long-term plan and shift the focus from acute to chronic, and to move away from hospital care to out of hospital care, to focus on population health and try to find strategies that we can keep people better at home for longer and increase the quality of life at home. So trying to move away from this sick care model, this revolving door where there's one in, one out, where I'm the doctor with a hammer fixing them, but then they go home and then they come back because we send them to what's made them sick in the first place. And in 2018, some of you will remember, but Theresa May, I think at the time, there was a loneliness strategy from the government, and that was the first time when social prescribing was taken seriously, particularly in England, and it was for the reason of tackling loneliness and isolation. In terms of social prescribing, this is what it looks like, and I'm not going to spend too much time on this because you've already described it, and I think Liv, you described it beautifully in terms of what you're doing and what you're not doing. But I saw a battle in the chat about signposting versus hand-holding and doing much more than signposting. So what I'm going to focus on in this diagram is the following, is this. Because if you imagine a patient go to their doctor, and their doctor clarifying that there's no medical needs, then they're able to refer, or particularly in England, this is how it works, you would refer to a social prescribing link worker. And this is where the magic really happens, is people like Liv who have the time to sit down, to dig deep to the root cause of what truly matters to that individual. If I was to say to that person, go do some gardening, go do some exercising, they'll say, yes, doctor, no problem. It's something that we've done for many years as doctors, but we know they would leave the clinic, they would never do it. And so what Liv is doing and all the other social prescribing link workers, they're building rapport, they're getting to understand those individuals, and they're able to do a lot more hand-holding in there. And then, of course, a menu of activities in the communities that people can be referred to. Sometimes they're being hand-held, and sometimes they're being taken there to make sure that they actually go there. Of course, you don't have to go via a doctor. So in England, anyone can refer, even your neighbor can refer you to social prescribing. You can also self-refer yourself to social prescribing. The question that I've had in the past is, can a doctor do social prescribing? Yes and no. Yes, if they had time to actually sit down and take a personalized approach and find out what really matters to the person. But in my experience, we do not have time because we send people from one place to another. And so we rely a lot on social prescribing link workers for that. And just a caveat to this, because this has led to a big debate, just to say that in England, the Department of Health has invested over £500 million in this from a national perspective, but, and it comes with a but, only the middle part is funded. So just the link workers, the social prescribing link workers are funded, their salaries are funded. We do not have funding for community activities, and that is very problematic because who delivers the activity and how are they getting paid? So the voluntary sector is put under immense pressure to deliver some of these activities. The National Academy was set in 2019 by the Secretary of State for Health and Social Care at the time, and the idea was to deliver social prescribing. We champion social prescribing on a national scale, and we support with resources and help link workers with information and materials. We look at the evidence. We try and get shared investment funds to support the voluntary sector to raise funds for the activities that they deliver. And of course, evidence plays a very, very big part for us. So these are some numbers from England in terms of what we've achieved. These are a bit out of date, so they've grown since then, but roughly we have around 4,000 now. I think the latest numbers are 4,000 social prescribing link workers employed, and that has reached, this number means universal coverage. So every single GP in the country would have access to a social prescribing link worker. So as a patient, you could access social prescribing all over England, in any practice that you would go to. We've had over 3 million now patient referrals to social prescribing link workers. And of course, the investment, which I've just mentioned earlier, since 2019. And there's been a commitment recently from the English government to increase the numbers, triple the numbers of link workers over the next 15 years, because we already have waiting times of 6 to 7 weeks to social prescribing in some areas. So as you can tell, when a service works well, it becomes overwhelmed. What is the impact? This is the evidence, which you can also find on our website, and I'll just share the website in a second. But just to say that in areas where social prescribing is being used, you have a 20 to 40% reduction in GP appointments for patients that are supported. You have a 15 to 25% reduction in emergency admissions. So we get to have a less strained NHS, and of course, financial return on investment, which, believe me, you may not care about that, but when we talk to the government, it's all about this. It's all about the return on investment in there. And of course, robust evidence showing that it supports people and their well-being and becoming more confident. In terms of what's next, there's been some exciting announcements. There's been a major health condition strategy for diabetes, musculoskeletal problems, dementia. Social prescribing was considered a core part of that. And there's a select committee that has called for a national social prescribing strategy and a strategy for children and young people, which I think in England we are lacking severely, and social prescribing for children and young people hasn't been as mature as perhaps we've seen in other countries like Canada and others around the world. And a few other news that came out recently from the Department of Work and Pensions that wanted to invest in social prescribing, and a green social prescribing fund for nature prescribing as well. There's been a lot of newspaper coverage, some good, some bad. I think sometimes it's being taken as fluffy. Sometimes it's being seen as comedy on prescription and what's it going to do for people. But actually, we, the doctors, know that without it, we would have a flooding influx of individuals that we would not be able to repair, quote unquote. And so social prescribing has been seen as supporting the NHS. This is very briefly the evidence that you can find on the website, whether you're looking for physical activity evidence or economic impact or arts, culture, and heritage. You can find it all in there. So please follow this link and read more and use this in your reports. This has been put together by a consortium of 10 universities, including Oxford, UCL, Imperial, and several other universities in the UK, and academics from them as well. And this is the international collaboration that Alison mentioned. This is an out-of-date picture, actually. We've grown much bigger than this. We have individuals from 32 countries, and Alison's representing Scotland in there, and we meet together to discuss progress and to share insights in social prescribing as best as we can and learn from each other. The term social prescribing link worker looks differently around the world, and it may look differently in terms of name, be it ASHA workers in India or Sheikatsu Shien in Japan, but either way, it has the same values of taking a personalized approach, co-designing, co-creating a plan together with the individual and getting support from community resources to make sure they stay well at home and in the local community. And this is the global map that Alison also mentioned earlier. So for those of you who are really keen to find out more what's happening around the world, we work together with a World Health Organization, and we put together a collection of reports from 32 countries now. This is last year's report, but there's a new updated report on our website with 32 countries in there. So you can see what Singapore is doing, what Australia is doing, what Canada is doing. And we've also got a short area for Scotland as well, and all the work that has been pioneered by all of you in there as well. And my final message as I stop, and I'm sure there'll be plenty of questions and a rich discussion, but if anyone's got any questions, please feel free to reach out. But I think the message for me is that if you imagine hospitals as a massive construction site, that's what really they are. They are there for repairs. People come in when they're already broken to us. The ideal world is stopping that repair and fix shop model that we've created. No more white-coated doctors telling people what to do, because true health starts within the community. It starts with people like Liv, it starts with people like Alison, within the community, and the voluntary sector that is able to support, maintain people healthier for longer. And the emphasis on prevention hasn't been put so far, but we need to move towards that direction. I hope that was interesting, and I look forward to questions, and thank you for having me.
Thank you, Bogdan. That was fabulous, and that really complemented. I think actually between the three presentations, that's given us a really useful picture. We're going to turn now a little bit for Sally Thompson from Grampian Hospital Art Trust to talk a little bit about their perspective on these issues.
Good morning. As I said before, I'm Sally Thompson. I'm from Grampian Hospitals Arts Trust. I haven't got a visual presentation for you. I was going to show you a film that I showed yesterday, but it actually expands into the other areas of our work, because Grampian Hospitals Arts Trust began 40 years ago, and we began by that concept of those fixing shops that Bogdan talked about. Those fixing shops were bland, white, and fairly unwelcoming, and where can art fit in to create them into a much more welcoming space? And that welcoming space is delivered by our collections program, which has got 4,500 artworks, which is in every single hospital in the Northeast. But that's not where I think the conversation this morning is about. I think the conversation this morning is about how we have developed, and I think the best description, as we said before, is as a community asset within the social prescribing model. And I really love the way Alison Leach said to us earlier on that people within the art sector think they're delivering, have an understanding they're delivering a social prescribing. I think you need to put it the other way around. We are part of the landscape of assets that social prescribers can access. We are able to develop those scenarios which support people who wish to have access to creative services to help support their well-being. I will describe our program, which is called Art Room. Now, Art Room started in hospitals 17 years ago. It was interesting when Liv said that description you said, Liv, about the informal. You said a person that came to you and said, I was accessing art within hospitals in the stroke unit. That was our project. So that was the beginning of something that happened 5-10 years down the line. It began in the hospital with an arts program called Art Room, which is still going in the stroke unit, by the way. But it stops when that person comes out into the community. So we've got Art Room, which is 2 artists who work, and it's based on a project which started in Glasgow by Art in Hospitals. It's 2 artists who go into work on the ward, and the conversation is person-centered. The NHS works with people. They fix people, fix patients. They work with patients. We work with people. So sometimes the NHS will refer that person to us on the ward. They'll say, we think this person may well really benefit from coming to the art table on Tuesday morning. Or in other scenarios, the artist will go around the ward in the morning and speak to people and tell them what they do. But when they come to the table, or at times when we go to them at the bedside because they're not physically able to come to the table, the artist doesn't say, oh, we're going to be painting, we're doing a painting today, or we're going to be doing that. They actually say, hello, who are you? What are you interested in? What would you like to do this morning? And if it's just sit and chat, absolutely fine. And again, we have scenarios where we've seen people walk past the door for 4 months and poke their head through the door and then walk away, because art, as we all know, is something that often people say, I didn't do that at school, I'm no good at it. So there's an understanding that you have to be good at art. And what Art Room does is it actually gives the person the choice to be involved in it. Now, then there was one time when there was a woman, I think it was either in orthopedic or stroke. She walked past the door. English was not her first language. She walked past the door several months, and they said, "Would you like to come in?" No. And then Suddenly they started setting up the table one morning, and the woman was sitting at the table, and they just quietly kept going. They didn't interact. And that woman then stayed for the next 3 months. She was a long-term patient in because of what was going. So she stayed and she stayed and she stayed, and she became a real devotee of Art Room, even though she couldn't speak English. It was fantastic. But what I'm trying to say is, when people are in hospital, you're at the room of the drugs trolley, the food trolley, your day is prescribed, your day is mapped out for you. In the Art Room table, you choose what you're going to do. The artist supports you, facilitates and guides you. It's about your choice, and it's about supporting confidence of trying new things. That's one of our outcomes these days, is people have the confidence to try something new. Now, if you think of somebody who's had a stroke, their whole new life has gone away. It's disappeared. Sorry, the whole life they had before, not the new life. The whole life has changed. What Art Room can do, amongst everything else that's happening, it can give you a new future, new hope. You've tried something new. You can do something. I can do this. So I'm going to move on from that hospital model that we delivered for right the way up until 2020. And we all know what happened in March 2020. Suddenly we couldn't get in. And we couldn't get into hospitals. And this is when we began to look at that community model. And it opened our eyes to how we as an organization can work in the community in what we call the transition space. So GAT works between art and healthcare. We occupy that space between the two. We are professional artists. We're not therapists, we're professional artists, and we know the cultural sector, and we train and we support artists work in this sector. We give them really robust training on how to work with vulnerable people, how to work with certain conditions if that's the area they're working in. But we also recognize the fact that when people come out of hospital, Liv's example was an absolute classic. They've really got involved in an arts project, and then it's taken away because they're now back in the community. What's next? So what we've looked at, so during COVID, we were asked to set up some projects in a community cafe. It was a request from a mental health part of the HSCP and Royal Cornhill Hospital, which is a mental health hospital in Aberdeen. It's a 12-week project, pilot project. We'd never worked in the community in this way before. And that project started in 2021 and it's now still going. And we are determined to keep it going. It's specific referrals from Royal Cornhill for people who are looking for, that they feel may gain something from the project that we're doing. From this, the Art Room manager said, this project has really shown us how there is a position between being in hospital and being out of hospital, where there's a safe space. Is there a safe space that we can support people still actually access an arts project? So we approached Aberdeen Art Gallery. We put it on a Saturday morning, so people who are working, who still have a need for isolation, social isolation, even if you're working, it's something that we recognize that people who are working may still would like to access something like this. So we set it up in Aberdeen Art Gallery. On day one, it was 15 people turned up. This is day one. Normally we're thinking 2 or 3 people. 6 months down the line, we might have 10. Day one, it's been 15, and we were actually quite worried that we weren't going to be able to, we were going to actually have to turn people away. But that project fits within that transition zone of people who've come out of hospital and will need another safe space. But we've also had Healthy Minds referring, and we can people coming to it of their own free will because they've heard about it, and it's a beautiful project, and that's the space that we're now filling in the social prescribing as an asset. We do not say that we are a social prescribing like Liv and like Alison. We're an asset, and that's how we can connect with that. Sorry, Chris, I've probably gone on a little bit too much.
That's really helpful to get that perspective. At this point, I want to if people have questions or want to get involved in a conversation around this, can you put your hand up so that I can see who wants to come in, who wants to engage with this really important area? Excellent. So, would it be possible? So, Margaret, would it be possible for you to, I can't see, Margaret McSweeney, could you, if you could turn your camera on and ask your question, that'd be great.
You may need to unmute, Margaret.
Yeah, we're not hearing you. Or if you want to put the question in the chat, I can relay it quite happily. Should we go to Joanne just in the meantime? Because Margaret's clearly having a problem with technology, with her technology just at the moment. Joanne.
Hi guys. I've just off the back of the Healing Arts Scotland conference across Glasgow and Edinburgh, and there was quite a lot of senior health and arts decision makers there, but there was also there was lots of people already engaged in our work and already big supporters and already in agreement with and aware of the research and the information. And I just came away wanting to know about what the barriers are and how we can meet those barriers. Bogdan, you did say that, the social prescribing network have been gathering an army, but I feel like we need to have a plan to really affect change at the highest level, because ultimately, as big as our army is, if we can't influence budget holders at a national level, there's more and more cuts happening, and as you all know. So I wondered, within the context of this this discussion, if we knew yet of any really senior level national activities, for want of a better word, that we can lend our weight to, that we might actually begin to see some policy change and some more a greater focus on preventative healthcare.
Well, I think probably that's one that Alison might pick up, just in terms of headlines, and then just in terms of what are the ways that people can support development.
Yeah, nobody ever says that social prescribing is a bad thing. I mean, you just get nodding heads. Yeah, everybody's like, yeah, you're right. I mean, I've lost count of the amount of people I've spoken to within the Scottish Government, and they all get it. It all makes sense. But when SSPM was established and we managed to get an end to the Scottish Government, because we realised, I think I touched on, in sports strategies, health strategies, arts, culture strategies, it was like everybody thought somebody else was dealing with it. It's like, oh, is that your job? Oh no, is that your job? So we that's how we managed to get somebody, the fact it's now a ministerial responsibility is brilliant, but that took 3 years to get that. And then you see it through social justice, you see it through housing, so it covers so many portfolios. I think that's one of the biggest issues. It's so complex in one way. I don't think it is, but it covers so many areas. It's like, well, where does this belong? And then David Robinson from the Irish Network, that was Ireland's biggest issue. They said, which box does this fit in? And it doesn't really fit. It goes over a lot of boxes. So until you can find a home for it, nobody wants to own it. And then if somebody does want to own it, they're like, oh, this is going to cost me money. So where's the money coming from? So many people say, well, I'm not doing that unless you give me money. And it really hurts my head, because it's not difficult. You've got this army, you've got all this will, you've got everybody telling you, the RCGP, they get it. Roisin and I both meet with the head of the RCGP. If you took a link worker out of a GP practice, there'd be war, because the GPs know that it works. We know that it works. all you people that support us by providing the prescriptions that we can refer to, you know that it works. But it's going to cost a bit of money. Now, I don't think it would cost a lot of money, but even on Wednesday, on the way to Glasgow, I bumped into a guy from public health, and he's saying to me, I've never seen it so bad about the cup. And that's what I've just heard that year on year. And it's like, and I know this is a bigger issue, but when is it going to get better? Because we know health inequalities are growing, we know life expectancy is stalling, we know the gap is widening everywhere. And it is going to take money. But so it's not that there's the will, I think it's the money thing that is stopping it. But I've said in the chat, social prescribing can only be as good as what we've got available to prescribe to. And you can't say we're a cheap option to take pressure off primary care or something else, but then think you can do it on the cheap, because you can't do it on the cheap, because you've got to fund the link workers, but then you've got to make sure all the resources that we use and rely, that they have all got to be funded and they all have their place. So, I mean, we kind of have to have a sponsor in MSP to get an in. And we sat him down and we were talking about how it cuts through all the other portfolios. And he said, well, just take 10% off everybody's budget, which I mean, I'd love to do that, but that is never going to happen because money is so tight, they're not going to give that up. But I do think somebody somewhere needs to really take action to get this moving, because the more we spend more money being reactive than it would to be proactive. And I know I've spoken to Bogdan, I am wrapping up. One of Bogdan's colleagues and I, we have spoken for so long about getting the 4 chief medical officers round the table and kind of saying, right, can you bang heads together? And even somebody from public health said that to me on Wednesday. Maybe that's what we do. And I have followed that with Monica Bogdan, so we maybe just need to chase that up. But I don't know if that answers your question, but that's what goes through my head.
And Chris, can I just come in for just 2 seconds, just on a practical note, I think as well, because I fully agree with what Alison said in there. I think, of course, for us in England, the home for social prescribing has been healthcare, because it was tagged along to the long-term strategy that was published in 2019. So it's just good opportunistic timing, I think, with the ambitions to move away from the hospital care at the time. So anchoring it into the existing narrative or future narrative of the NHS or existing government is really important and was very important for us. Is healthcare the right place for this? I'm not too sure. I don't know. It's been for us in England, but we know in different countries actually around the world, community has been the home for social prescribing. For us in England, the government invested in it, so therefore that home became very stable, and so we decided to run with it as healthcare because we had huge demands on the NHS. But I think the key that got us to where we were is exactly what you're all doing at the moment, and you need to keep doing it and push to that frustration barrier, which is democratizing health and proving to people, Arts Council, Sports Scotland, and once again, all of the big stakeholders, the big organizations to support each other and to join in this coalition and this partnership, because health crosses boundaries into their territory as well, and is their job too. And so getting everybody around the table, getting everybody to chip in and to support, it may not be funding, but it may be a stadium that people can use for those activities. It may not be, it could be a museum and so on and so forth. So chipping in and getting stakeholders together for conversations is very, very important, which of course you're already doing, but those were some thoughts from me.
So we've got 2 hands up. Jackie Sands, hands up. Jackie, do you want to come in? And then we've also got Roisin after that.
Yeah, thank you. I'm really thinking very much.
You want to just introduce yourself, just so we know. It's
Hello.
okay.
My name's Jackie Sands, and I'm the lead for Arts and Health for NHS Greater Glasgow and Clyde. So promote art and creativity across the system and support communities and building projects and artists' involvement in healthcare. This question around reimagining health and the responsibility for finding the funding for social prescribing. Healing Arts Scotland has happened this week, which is really ramped up the volume around all of this work, but at the same time there's been a threat to, well, the government's not committed its funding to Creative Scotland, and we've been actually using Culture Collective money out in Inverclyde for researching what kind of social prescribing projects work. I was in the Reimagining Health with Margaret Robbie from Public Health, Angelina Foster, and our Director for Public Health. And that was really interesting because we were talking about there are capital lines of budget and there's revenue budget. And this is what Joe Brown was asking, just, you know, and what was muted in that discussion was we need to create a third line of budget for preventative healthcare, because there are many areas of vulnerability at the moment. And yes, we do all club together with our assets and building stadiums and whatever, all these things, we do all of this. But if there was a stable line of budget through public health, that would be a start.
Okay, Roisin.
Hi, so I'm Roisin and I'm the project manager for the Scottish Community Link Worker Network. So it's just really to follow on some of the kind of chat and comments just about funding. So so this week, like, we heard the sad news in Scotland that both the Community Link Worker programme in East Dunbartonshire and East Lothian are both closing. So funding's a real issue, not just for the services that community link workers refer people onto, but also for the community link worker programs themselves, because they're vulnerable to cuts because of the deprioritisation of the programs through the 2021 general practice contract revised MOU. So the real issues around there. I mean, I've been working in the voluntary sector for 30 years and I'm sick to death of talking about short-term funding. You know, it's been something that has just been ongoing. There's a consultation at the moment out on third sector funding principles, and I'm hoping that the Scottish Government will listen to all the feedback that's come back from that. But I think in Scotland, we need to get much better at being able to evidence the work that we're doing. Alison mentioned the national review for community link worker programmes that's going on at the moment. And one of the things that we're going to be looking at as part of that is better data and evidence, because as Bogdan very rightly pointed out, the economic return on social prescribing is huge, but people don't take or pay enough attention to that. And just finally, being at the NHS Scotland conference a few weeks ago, the delegates there were asked about what would be the most important thing for the NHS going forward, and the answer was prevention. So while we're seeing cuts in funding, both at community level and also, you know, with community link worker programs, you know, we need to be able to push that message forward. I've been talking about it long enough and I'm sick to death of talking about it.
I think that's a really useful context. I think we're going to, if there's one more question, we're going to go round the speakers and ask them for one key point each, one takeaway from the discussion. And I'm going to, Sally, what's your one takeaway? Sorry, put you on the spot. You didn't expect me to. You need to unmute.
No, I wasn't expecting that, but yeah. I'm just.
So I'm going to. No. I was just going to say, Liv, I'm going to come to you next, and then Alison, and then Bogdan. So the rest of you have some warning which order it's coming. Sally, go on.
I think I'm going to give you a takeaway from the whole week. What the takeaway from the whole week has seen that there is so much rich discussion, rich engagement in this area, both social prescribing and the arts, how the arts can get involved in well-being, and the fact that there is this rich. But like Roisin, I've been working in this sector for 30 years and I'm still having the same conversations. But I do feel that each time, each 10 years, each decade, it just moves up just one rung. And it's just moving up just one rung. And as I move into my retirement years, I'd like it to move up one more rung before I leave.
Liv.
Yeah, I suppose I can say I've worked in the health sector for over 40 years, and it's still the same conversations. But I think what the third sector needs to do, and one thing I've been on about for years, is actually become closer together, work better together. Because of the way that funding is for third sector organisations, they're very protective of what they do. They're not keen to sort of link up together. And I think, you know, if they were able to do that or willing to do that, I think that would be a strong message to say, look, you know, we're trying to do stuff. We're trying to do as best we can for preventative sort of whatever. So, you know, give us, you know, some funding or give us resources to be able to take that forward.
Yeah, I think actually it's interesting because one of the things that's been going through my head through all of this is that my sense is that, and it came up yesterday, this question of being very clear about outcomes, and being able to go to a link worker, we do this, these are the outcomes we deliver, enables link workers to make really effective judgments about what sorts of support are appropriate for people. So I think I think there's an awful lot of very good practice amongst arts organizations, and it needs to be shared. Actually, it needs to build capacity, because actually if you end up with a framework in Scotland, then actually for the arts to participate in a framework requires real consistency of outcomes across the piece. So sorry, I shouldn't
Chris,
be
I was
doing
going to
that.
say, I'm going to remind our timekeeper that we're at time, so it'd be really
Okay.
nice to hear
Sorry,
a very quick.
Alison was going to come, and then Bogdan. Thank you, Nancy.
I think my takeaway is that there's just fantastic work happening on the ground. Everybody wants people to get better, and we know that all GPs can offer, and no disrespect to Bogdan, is a paper prescription or a drug. I heard on this morning on the radio earlier, somebody saying the most underused antidepressant is exercise. But that could also be arts and culture. That could be a cooking group. That could be something else. My hope is that we really can make a move away from being reactive to being proactive, and we have to take the public with us, and working collaboratively. Just as Liv said there, bringing primary care and the community together can only bring better outcomes for everybody. But we need the data and we need the evaluation to be able, because we still have to prove our work. So we've got a long way to go, but I have hope.
Brilliant. Bogdan.
I'll keep it short and sweet because it's all been said already. For me, it's hospitals are for repairs. Health starts at home and in your local communities. If you reached me in the emergency department, I feel like it's already, we've not done something right in the first place. Yes, you'll need medicine, but actually there's so much more you can have within the local community. And finally, shared leadership, exactly what you've all demonstrated. Clear communication and collaboration, absolutely crucial. I don't think Alison ever saw this as a job, but she was always emailing at 9 p.m, 10 p.m, joining conferences in London, meeting with international partners. So please keep doing that. And thank you all for everything that you're doing, especially those of you who are link workers. Thank you.
Nancy.
Well, thank you very much for everyone who's joined the call and everyone who has been a speaker on the call. I know that sometimes it feels like we're having the same conversations again. However, I feel we're at a point right now, like Alison and Bogdan have talked about, if we're joining forces, joining voices and keeping the pressure on. At the moment, there are a few things going on in Scotland through the Human Rights Bill, the potential of a Wellbeing Bill, where some of the structures in place and some of these barriers about the way the systems work will have to be addressed anyway for wider reasons, and gives us maybe an opportunity to really push some things through. Arts, Culture, Health and Wellbeing Scotland is a network in this space that works across a whole range of areas, and obviously ties in with some of the lead people like the networks that exist, Alison, etc., across the UK and Scotland. And our our role right now is to look at some of the conversations that have been started this week, some of the connections that have been made, and make sure this doesn't end today, and that all the momentum that's been gathered sort of falls aside. There will be a report coming out, sort of trying to gather some of the feedback from this week, and then we'll be looking at some of the areas we'll be able to try and bring more conversations together to try and move forward. So if you want to know more, I would encourage you to go onto the website. It's ACHWS or ACHUS.org, and you can sign up for our newsletter. We do activity across the whole year. We are here all the time. And I would encourage as many of you as possible to connect with us, so that if we're able to, we will keep connecting and making conversations. Or if Alison is looking for wider support to take things forward, we can use these resources to make sure that we're putting weight behind the areas that we need to collectively in Scotland, and to really keep the pressure on. I think that's as much as we can do for today. But listen, thank you very much. If anyone is interested, there are 2 other online calls today. One of them is looking about what the research says, again, on a UK and international level, with some great speakers. And our last one today is tied in with the event that's happening in Orkney, and it's looking at how culture and health practice and island communities work together to provide co-production of work. So those 2 are still available on Eventbrite if anyone wants to sign up. And I wish you all the best Friday, and a great end to the Healing Arts Scotland week. Thank you.